Well, I guess we'll get started. It's 2 o'clock. 2 o'clock in Montreal anyway. Montreal is covered in ice, but we've made it to work, so let us go. First of all, hello and thank you for joining us today. This webinar was put together by the National Collaborating Center for Infectious Diseases and the NCC for Healthy Public Policy. Before we get started, just a reminder that we are recording this webinar, and your comments in the chat box will be visible, and they will be visible in the recorded version. So keep that in mind. The PowerPoint that we're using today, as well as the recording of this webinar, will be available online on the NCCHPP's website, and we will send a link to everyone after this webinar to show you where it is. Our colleague Mylène McGuire is also with us here, and she will be able to help out with any technical difficulties that you might encounter. So please use the chat box to indicate if you're having problems, and we'll do our best to help you out. So to ask any questions or make any comments during this presentation, please feel free to use the chat box. And we want to acknowledge that there's a good deal of expertise out there amongst the participants as well. So please feel free to share that with others. The more chat, the better as far as we're concerned. And so we really encourage you to use that. We're very pleased to be joined today by two invited experts. One, Dr. Nitika Pant-Pai, who's an associate prof at McGill University and is also involved with the McGill University Health Center. She'll be sharing her expertise with us, as well as Dr. Mohammed Khan, Medical Health Officer for the Kelsey Trail Health Region in Saskatchewan, and he'll be speaking to us later on. I'm Michael Keeling, and I'm also joined here by my colleague Olivier Barfleur. We're both with the NCC for Healthy Public Policy. And this is a good moment for us to highlight the work of our colleague Geneviève Boilly-Larouche from NCCID. She has played a very big role in putting this webinar together, both in terms of making this PowerPoint and in helping us to organize it. So our thanks to Geneviève. None of us have a conflict of interest to declare. Our national collaborating centers are part of a network of 6 NCCs across Canada, and they are financed by the Public Health Agency of Canada. And while we have a map of Canada in front of us, this would be a good moment for us to ask you where you're dialed in from right now. So if you'd please just click on the province, or if you're from international, please just let us know where you're dialing in from. On the registration list, it looked like we had all but one province and all but one territory represented. Let's just see if everybody's here today. Take another moment to give you a chance to check in. Nobody from Nova Scotia yet. So we don't have anyone from Nunavut. We don't have anyone from PEI. But all the other parts of the country, it seems that we've got someone on the line. That's great. Okay, let's move along. Back when you registered for this webinar, we asked a few questions, some about infectious disease and point-of-care testing, some about public health ethics. We just wanted to see where people were at in terms of your self-assessed level of knowledge. Here's what you said. This is a quick summary of your responses to those questions. So a fairly knowledgeable crowd, actually. We used this information when we were planning, so we're trying to build it to fit with respect to what you said about that. Again, there's a fair bit of knowledge online, so we would ask you to share it along the way through the chat box. And we have 3 main goals today in presenting this webinar. The first is to introduce point-of-care testing, or we'll use the acronym POCT, and discuss its potential in the Canadian context. And we'll be asking Dr. Pai to present on that. She'll have a lot to say about that. Secondly, we wanted to use an ethics framework to help us to identify some of the ethical issues that arise in a case study involving the use of POCT to expand the HIV testing offering. So we will explore ethical issues involved in that. And third, we want to provide you at the end with some additional resources on point of care and on public health ethics. we realize that in an hour we can only cover so much material, but we do want to find windows for you to find out more. And we will always encourage you to contact us at our respective NCCs, and we can link you up with more information as well. So before we go any further, let's just start with the problem. And this will be an object of our discussion for the rest of the hour. In many rural and northern settings in Canada, people have limited access to HIV testing. This can be due to stigma and discrimination, can be due to geographical challenges, and that includes suboptimal or no laboratories, can be due to a limited testing offering, and also to population migration. While we know that HIV diagnosis is clearly essential for preventing its spread and for helping to manage HIV for those who are infected, access to effective and timely testing is very limited it can be very limited for people living in the north or in remote regions. So that'll be the context of the problem that we consider. So given that we have this problem to deal with, we have to consider what are we going to do about it and how do we decide? Now there are a lot of factors that can be involved. They can frame, they can motivate, they can influence, inform. They can also be used to justify the responses that we might come up with to this problem. We'll just list a few of those potential factors here. There are many, many more. But what we do want to indicate, it's not just evidence that drives the policy and program responses to the problem. It's not only the evidence that motivates what people do in terms of coming up with the program, nor is it just ethics. Now, what we want to say is we want both evidence and ethics to be a part of the potential solutions or the potential responses to the problem. And those will be the object of our focus today. But these others can be very influential in terms of how people develop programs, how they decide what to do. We would also invite you to have a look at this list as we go and to indicate any other potential influencing factors. If something else comes to mind, feel free to use the chat box and put it in there. So, given the problem that I just mentioned a moment ago, here's one potential response to that problem. And this will serve as the case study that we'll use for the rest of the hour. And that is a point-of-care HIV testing program, a pilot project, in rural and northern Saskatchewan. And this is a fictional pilot project. Just want to make that clear. It's not an existing program. So, given the problem, in order to improve access to HIV testing for rural, northern, and indigenous populations in Saskatchewan, 3 Saskatchewan health regions have collaborated to introduce a pharmacy-based point-of-care HIV testing pilot project. And it has 4 major goals. One is to expand access. Another is to offer testing in non-traditional settings, so extended opening hours, no appointment required. Another is to offer more options that don't necessarily involve GPs in hospital settings. And another is to prevent loss to follow-up type situations by providing rapid results so that people are still in the room when they receive the results of the test. So they're not out the door and then you get a positive test and you can't tell them what happened. It may be difficult to find people afterwards. So those are the goals. Now just some details on the project development. There were 3 main steps in the conception of this project, this fictional pilot project. Those main steps were identifying engaging partners. They involved preparation and implementation, and they involved evaluation, which includes some research factors. One thing I do want to point out here, we need to note that there, on the bottom left, in the identifying and engaging partners, there was a consultation dimension that involved various stakeholders, including CBOs, tribal councils, indigenous leaders, nurses, GPs, and Ministry of Health. So there was a consultation process. Now, based on this little bit of an overview, and before we get into too much more detail, we just want to check in with you as to your initial impression. So, do you think this is a program that you ought to support? We'll ask you to vote now. Yes, maybe, or no. So go ahead and vote. Looks like a lot of undecided. We're approaching, well, we're a little over 60% undecided, but almost 40% yes. No no's yet. Okay, so let's say 37, 63. All right. Just wanted to check in just to see the initial thoughts on the matter. We will come back to this same question after we have a little more discussion. Okay, so at this point, we want to focus more on point-of-care testing, and we're very pleased that Dr. Panpai joined us to share her experience in the field. I'm going to turn the microphone over to her, and hats off to you, Dr. Pai, for your getting through the ice today to join us today. Much appreciated.
Thank you. Thank you, Michael and Olivier and Genevieve and Dr. Khan. Good morning, good afternoon, everybody. It's quite treacherous out there, and I've survived. I just gave grand rounds at the Glen, and now very happy to talk about point of care to a very engaging audience. So as Michael beautifully framed the problem, a probable solution to helping communities consider testing is point of care. But let's just elaborate a little bit about the attributes of point of care technologies before we can make up our mind as to whether we should or should not introduce the technology. So why point of care? So this is how I've structured my talk. I'm going to talk about the need for point of care, then a couple of points that need to be kept in mind while introducing point of care, HIV situation in Canada and the role of point of care and where it fits in. So it's 2017, and as we know, we are entering the brave new world of HIV diagnostics and diagnostics the world over. We have we are going to get real-time data, personalized data from people, because a lot of our patients and community members are into wellness. We have connectivity. The smartphone and internet penetration in Canada is about 85%. It is supposed to reach 95 to 100% by 2020. And so at point of clinical care, so point of care POC, the acronym stands for point of clinical care or point of care. These are devices that can be used anywhere. They can be used at home, for example, self-test. They can be used in pharmacies, and they can be used in outreach settings. Mobile smartphones since 2017, and as you know, mobile smartphones have become extremely useful because they can be adapted using several different smart apps and dongles to serve as diagnostic tools. For example, in this picture here, you can see that a smartphone can be used to examine the fundus, and a pulse oximeter device can also be attached to a smartphone, and you can actually read real-time oxygen saturation levels. You can also use a smartphone as a portable ultrasound tools. Wearable health technologies are in. They can be used for wellness or treatment or adherence or monitoring. And real-time data collection goes on with these devices. All of them are connected to a web server. And you can know what's happening in the lives of your patients by communicating via a dashboard. We're also talking about Fitbits and iWatches and Omwear. Omwear is a company based in Montreal that manufactures smartwear, where smart devices are integrated into the fabric of the t-shirts, and you can actually get parameters, vital parameters through them. The Android tablet has now become a health technology assistant. You can have smart apps downloaded onto these tablets, and you can collect a fair amount of data from your patients and also use smart connections to measure blood pressures, blood sugar. You can also do hemoglobin count. You can do EKG tests. In fact, FDA has recently approved a device that can perform EKG. So in this setting of connectivity and mobile technology, you imagine 2025, I think the tricorder is not really far away. And if you remember, those of us who loved and grew up on Star Trek, the tricorder is one of the devices that can be used to screen for your own DNA as well, and of course screening for biomarkers. But before we go there, we need to first absorb the essentials of point of care, and there are 5 points that I would like to kind of highlight, and they need to be kept in mind. So those are, so we need to define point of care, we need to know what the criteria are and what is the spectrum of its use, what are the essential conditions for its functioning, what needs to be improved, is technology alone enough, and what lies ahead in its envisaged implementation in Canada. For HIV and STBBIs, which is the field that we really talk about, there are different kinds of point-of-care technologies. There are the multiplex technologies that are biomarker-based. In fact, these companies are based in Canada. There are duplex technologies with HIV syphilis. Multiplex technologies have Hep B, Hep C, and HIV. Then there are point-of-care CD4 devices, point-of-care viral load devices that can actually detect your detect viral load RNA, and CD4 counts can be picked up in a span of about an hour and communicated to your smartphone. Then there are a lot of fabric-based devices, nanotechnology, chip technology, and barcode devices that are coming out in the market, impedance devices as well. So there is a gamut of point-of-care technologies that are going to be for us to choose, and so we need to know which device fits our needs and our populations and does the job. The key theoretical things that we need to keep in mind with point of care is to understand what exactly does point of care mean. So these point of care technologies have are technologies or tests that can be conducted nearer to the patient, at the patient ideally. The notion is to bring the test process very close to the patient so that the patient's physician can hasten the process of screening and diagnosis and expedite patient care. So the point is not to just screen and leave the patient, but to really decide, make change in the treatment or screening or diagnostic probability, whichever probability the physician wants to change, and to really think about expediting and making sure that the patient gets back to the facility or gets linked to the facility or gets sent home. These were first proposed historically for ICU use and in the ER. The first few examples of point of care were the CABG, hemoglobin, and cardiac markers. And many of you are experienced in the field, and as you may have seen, CABG and cardiac marker point of care tests are very, very effective in in picking up a troponin, and CABG is also very effective and highly accurate. So these biomarkers-based devices are being marketed in many parts of Canada. The first definitions of point of care that were used were all lab definitions, the GOLDs. In fact, they were first proposed by Coast in his book, Gold's Guidelines and Principles for Point of Care Testing. And later on, these definitions evolved depending on where these point of care tests, they started out in the lab and ICUs, and then they moved to the outreach settings. And so a few slides down the line, I'll explain to you some new definitions that have come up. But the goal of point of care at the end of the day is rapid clinical action. These tools aimed to provide or help with decision making at point of care. It could be triage. It could range from triage to rapid confirmation. The idea is to reduce professional time, to reduce the number of visits that the patient has to make to get a screening test or result, to increase the number of people screened with use of point of care based strategies, or increase the number of new infections that can be detected with these devices, and ultimately get to the next step in the clinical pathway. If the patient is diagnosed to be preliminary positive, get him into getting screened for confirmatory tests. If the patient is negative, make sure that in the context of HIV, provide him risk reduction counseling and send him home. So ultimately, the focus of point of care is not the technology, is not the tool, it's clinical action, because that's what we really want. And why is clinical action important? Clinical action is important because that's what really matters. A tangible clinical impact leads to a tangible public health impact. And a tangible public health impact is quantified by a reduction in disease burden, which is estimated by reducing the transmission. So we are basically talking about this flow of action from a rapid clinically actionable result to change in providers, that leads to a change in provider's decision, that leads to a correct treatment or management choice, and that improves patient outcomes. Ideally, all of this should happen on the spot in one clinical encounter while the patient waits, at least on the same day. In some settings, this cannot be accomplished on the same day, and that depends on the setting. But in sub-Saharan Africa, HIV tests are being or have been used for the past few decades, and results have been communicated to them on the same day. What does clinical action further entail? So clinical action really entails, to elucidate, a rapid completion of the test and treat loop in the same clinical encounter to make sure the job gets done. And what does that mean? So when the patient comes to you, patient is seen, the test is ordered, test is performed, and the results are reported, the provider has to make a decision as to whether he or she needs to start treatment. And that treatment could be anything. It could be start the drugs, start them on antiretrovirals, or order confirmatory testing in parallel, or in cases of while we use CD4 or viral loads, you could use it to modify treatments. You can also change or order discharge summaries or decide to admit a patient. Whatever the case may be, the idea is to lead to clinical action. Like I said before, the original goal of point of care started with lab actions. It was in the ICU that point of care tests were used, and they were very effective. But in recent years, in the global context, there have been a shift towards goal-oriented definitions of point of care, and that has been basically driven by the need to provide tests to patients or poor patients in sub-Saharan Africa who take one day out of their lives to get one HIV test. And the idea is to make sure that they get to see the doctor, or they get their next, one of their return visit gets reduced. So the point of care testing definitions have changed to being viewed as testing that will result in a clear actionable management decision within the same clinical encounter, that is ideally within the same day. Now on to criteria of point of care. So the earlier criteria of point of care that was proposed way back about a decade ago was the assured criteria. The assured acronym stands for point of care tests should be affordable, they should not be very expensive, and there is a confidence interval to that understanding. Of course, the ideal affordability varies with contexts, but if you're talking about in Canadian context, it could be $10 to $15 or even less. In the African context, it could be $1 to $2 per test. Then the ideal point of care test should be highly sensitive and specific. And this sensitivity and specificity ranges really varies, but in the context of HIV, we really have no excuse. We have sensitive tests that are 99% sensitive and specific tests that are 99 to 100% specific. The ideal point of care test should be user-friendly. Any lay healthcare worker should be able to operate a point of care or operate a point of care testing strategy in the field settings. And the test should be rapid, robust, equipment-free. They should not be, we should reduce the number of steps it takes from taking the sample to getting the result. And ideally, we should not use an equipment, and it should be deliverable to those in need. So this was one of the ideal assured point of care criteria. But there have been changes to this criteria, and there have been modification by another group based in Seattle. And that is illustrated in this panel, on this panel 3, which states that point of care tests should allow for a quick clinical decision. It should be used by healthcare workers. It should be there should be a low average cost per test. There's no range mentioned to that criteria. Of course, it makes it very open, and it should certainly be rapid, provide result during a clinic visit or within a reasonable waiting time. And it should have an acceptable test efficacy. By that metric, we mean test efficacy is equal to likelihood ratio times patient notification rate, which means a likelihood ratio means the likelihood that a patient can get a positive result in one setting, multiplied by the likelihood that the patient is notified of his or her result. So that translates to the efficacy of a point of care test. And the test should be cost effective. And that cost effectiveness, the term in itself varies with the context and settings. So there's been move in defining the criteria also globally. Point number 3, now on to point number 3. A rapid turnaround time is key to efficiency of care, and that is the key point of care test. For example, At every step of the test and treat, HIV test and treat cascade, as we know globally, and this is estimates from WHO, 25% of patient gets lost to follow-up. So if 100 people are screened, only 25% are left in care. And we are trying to change this paradigm by offering novel testing strategies and by making sure that those tested also get retained with smarter linkage strategies, and those that are linked to care also remain in care. So with an action plan that includes point of care testing and innovative technologies that can improve losses to follow up, I think the test and treat cascade could probably be improved. So one of the reasons why a rapid turnaround time is really important to the point of care testing efficiency is because in South Africa, as you know, it takes about 1 week to 3 weeks to get 1 to 3, depending on the setting, to get a confirmatory test result. And then again, from there on, 3 weeks to 6 weeks, or even more, sometimes 6 months to get linked to counseling. And so by the time the patient gets initiated onto treatment and obtains a known CD4 or viral load count, it is about 6 months down the line. So this kind of a paradigm is not really acceptable, and there are movements across the globe in trying to expedite this so that people can stay longer in care and can get expedited to care. There's another example from India that explains that rapid TAT varies in context settings and infections. In India, for example, it can take about up to 8 days before treatment is started after a patient is picked up as sputum smear positive. And that means that there is a high likelihood of the patient dropping out of the cascade of care. So the point of care is to eliminate at least one return visit. And so as Stephen Lawn put it really eloquently, as the late Stephen Lawn put it, he says that the diagnosis treatment gap will only be closed by rapid point of care assays if they're used in the first clinic visit, and physicians are allowed to make treatment decisions immediately, and patients save one return visit. Now, this has become really important because, as you may know, GeneXpert has been rolled out in many countries, and GeneXpert is a very effective, a very accurate point-of-care test for TB, and it provides same-day results, and it also allows for immediate treatment initiation and eliminates a return visit. So this has been shown in many cost-effectiveness studies to reduce the costs of rolling out a program. Now on to point number 4. So as you've seen, there are different definitions for point of care, the different criteria. The key to point of care is to change the treatment or clinical action plan for the patient to make sure that the patient saves at least one return visit and there's rapid turnaround time. But point of care technologies can also are offered across the spectrum of care. They started out with the labs, and now, as you can see in this figure, they can be offered in the homes. So self-tests are becoming really important because self-testing is an innovative strategy of allowing people to test in their homes, because we know that about half of the people on this planet do not know their HIV status, and it is really important for them to get screened and initiated into care if we are to meet the UNAIDS HIV 90-90-90 goals, which is 90% people have to be tested, 90% people have to be treated. Of those tested and of those treated, 90% have to be retained in care if we are to control HIV by 2030. So one of the TPPs, or target product profiles as we call them, are tests that can be performed in the home. Then we're talking about tests that can be taken to the communities, and these could be performed by a minimally trained healthcare worker, and these include the rapid diagnostic tests that we know. Examples are INSTI that we are familiar with in Canada, but internationally we have Determine, and these are dipsticks, and the primary purpose of these tests is triage and referral. The next spectrum on the other TPP that is really popular is the one where a patient comes to the clinic and point of cares are offered by doctors and nurses. And for this, you can either use the rapid diagnostic test or you can use handheld instruments. And the purpose here would be to diagnose and to treat them. Now, another TPP could be point of care tests are actually offered and used in peripheral labs. And if you speak to manufacturers, you'd be surprised to know that 70% of their bulk usage of point of care is in the labs, because when they do not want to batch samples for ELISAs, when they get fewer samples, then it's easy to conduct a rapid point of care. But the type of point of care that they use in the labs vary from rapid diagnostic tests, the biomarker tests, to microscopy tests. And they are certainly used for confirmation or for treatment or monitoring. And the last amongst the target product profiles are the hospital use, tests that are used in the hospitals at bedside, and that we are familiar with. They could be of varying complexity. But whatever the technology, big or small, whether we use fancy, complex equipment in the hospitals, or we use these immune-based biomarkers by healthcare workers, or we use self-tests, whichever the technology that we use, point of care has to be a tool that expedites the process and pathway to clinical care seeking. We can come up with portable devices, but sometimes portability does not guarantee implementation. And this kind of segues into what Michael talked about. So it's not just the technology or the scientific evidence or the ethics that pans out when we roll out a strategy. It's also the context and the contextual factors that play a role in kind of in implementing a technology. And often, as we say, the technology is not enough, because we are talking about tools that can help us in the spectrum of clinical care. If we need to roll out programs in northern communities, we need to have a healthcare system that is going to embrace them, that will enable their use, or that will facilitate their introduction. So for that, we could probably have them supported by programs, by regional, provincial health programs, and we also need sustainable business models to keep them. If you'd like to know more about diagnostic testing, you could read our publication, What is the Point? The last fine point that we really want to talk about are what are the essential conditions that are essential for point of care to thrive. So, of course, we should have a very good product that has good accuracy. It should be tested and evaluated and validated by many different people in different contexts and settings. But for an enabling environment and for allowing a point of care culture to thrive, we need a trained cadre of healthcare professionals that are familiar with the QA/QC protocols, that maintain logs of POCT tests, and also can perform proficiency testing, certification. They are the ones that will keep the quality of POCT, because ultimately they are screening tests and a lot depends on the first test. Then there's data management, interpretation, reading results, and storage that are also important, that needs to be kept in mind. And finally, even if you have a technology, you need to integrate these results in clinical care. If you're not going to communicate these results, you're not going to store the results, if there's going to be no action plan and no record of the action plan, and the point of testing anyone is lost. If we are thinking about rolling out a strategy, then we need sustainable models. These could be newer models, disruptive models, but they must be patient-friendly. We need to specify who will pay, how much patients will pay. Poor patients do not have deep pockets, so we have to keep them affordable. And we also need scale-up services that are maintained over time, because we do not want to introduce point-of-care tests and then take them away if they're really loved and accepted by communities. So, yes.
We're running out of time, so I'm going to have to ask you to wrap it up.
Okay. So why do we think POC use will benefit Canada? Because we know that in Canada, there are about 71,000 is an underestimate. There are about 75,000 HIV infections, and nobody knows how many people are unaware of the serostatus, but the range is between 15 to 25%. And there is a high HIV burden in key populations. The estimated cost of HIV infection is about $4 billion. So with the late presentation being a problem and people presenting really with advanced disease, I think there is POCTs can really help. If they are integrated with healthcare services, they form an excellent screening tool. POCTs for HIV, and I'm looking at the questions here and I could answer them in great detail, but they are known to be highly specific and highly sensitive. And they are first-line screening tools, so they certainly need to be confirmed. And if they are approved in Canada, self-tests will help people to know their serostatus. I think Canada is soon on its way to approve self-tests. In outreach settings, we could introduce multiplex tests that can screen for many infections in one visit, and I have considerable experience with that for HIV, HCV, Hep B, syphilis, CTGC. You can screen them for a whole gamut of infections. And ultimately, with early detection, timely linkages that can save lives, and early treatment initiation, we can reduce transmissions of new infections over time. So I like to talk about Buddha because I think Buddha says we should not dwell in the past and we should not dream of the future, but we should concentrate the mind on the present moment. And I hope that we're all concentrating on point of care technology at this present moment. If we are to really embrace the point of care induced change, I think we need to embrace the change. We need to make wise choices and make sure that they are guided by clear principles. I do believe that point of care technologies can be game changers because they can be used for biosurveillance, they can be used as tools for screening and triage, they can be as self-tests, they are great empowerment tools. If we teach point of care diagnostics in medical schools, we can induce a behavior change in providers to incorporate them in clinical practice. They are great tools for community engagement, for expanding primary access, for sustainable innovation. So with that, I think I would conclude and say that as Darwin said, it's not the strongest of species that survives or not the most intelligent, but it is one that is most adaptable to change. So we certainly need more diverse, more portable, excellent technologies, but we also need a good environment. Thank you. I would like to thank Geneviève, Michael, and Olivier, and my sponsors. Thank you.
Thanks so much for that, Dr. Pai.
No problem.
Sorry to rush you at the end there. What I'm going to propose we do is we will take some of the questions and we'll address them after the webinar. I think it's more important to have this presentation in as much detail as we can, and we will send a link and we will deal with some of the questions as best we can afterwards. We may have a bit of time for questions at the end as well and for discussion.
Mm-hmm.
Now, I'd like to turn to a consideration of the ethical side of things, and with that I'm going to pass the microphone to Olivier.
Thanks, Mike. So why should we care about public health ethics? One way to look at it is to ask what we need to know to act with professionalism in this situation. We clearly need to know what point of care testing is, and thank you for the good presentation there, how it works, whether it is a viable option for improving health outcomes for remote and northern communities, and lessons and best practices for successful implementation. But we also need to pay attention to the effect of our actions on groups and individuals, recognize which values are promoted and which are diminished by our actions, and be able to deliberate about options, weigh the good and the bad, make decisions, and justify them. And since ethics can help in these regards, that's one reason why we should care about public health ethics. There are various approaches and tools that can help us see and think about ethical issues. We can use codes of ethics, ethical values, principles, ethical frameworks, case studies, theoretical approaches, and intuitions. It is important to realize that we can use these to look at ethical issues at different levels. At the macro level, for instance, we can look at the implications of policy or population-wide intervention. We can ask if, for example, we are promoting more equitable access to diagnostic technology. At the middle level, we can look at issues arising at the level of organizations or groups. We can look, for example, at the training and support that will be offered to pharmacists. And finally, at the micro level, we can look at issues rising between a few individuals. We can look, for instance, at what happens before, during, and after each step. Chances are the issues will be quite different at each level. Today we'll use a framework to analyze some of the ethical dimensions of our case. One of the reasons why frameworks can be useful for public health practitioners is that they can help you identify and deal with ethical issues, especially if you're not an expert in ethics. But they will only help you. They won't do the work for you, especially when it comes to critical thinking. It is important to know that there are many frameworks to choose from. Today we'll try one out as an example of what a framework can do. It's a good framework, but it's really just an example. We are not suggesting that it's the best framework for you to use. We are very lucky to have Dr. Khan with us on the line today. He will lead us through the ethical analysis of our case using Nancy Cass's framework. It's a simple but effective framework that is structured around 6 questions. The main elements of our case, as you recall, are a point-of-care pilot project in Saskatchewan to expand access to testing delivered by pharmacists, to eliminate delays in receiving test results with a research dimension. And with that said, I'll turn the microphone over to Dr. Khan.
Thank you. Good afternoon, everyone. I hope everyone can hear me clear. Okay, good. So as it has been mentioned, this is a hypothetical case that we are trying to implement in northern Saskatchewan. And I would just like to say that point-of-care testing is one of the pillars of our provincial HIV strategy, and we are trying to expand the point-of-care testing centers throughout the province. We have many, but basically they are in the acute care settings, and basically they are for antenatal care if a pregnant lady has not been tested previously or the results are not available. She could be tested before delivery in case of a needle stick injury or an assault case. These are done. But in this hypothetical case, we are suggesting that we should start point-of-care testing in local pharmacies, and the pharmacist could do that with a prick. So we are making some assumptions that it has been approved in Saskatchewan, that pharmacists can do the test with a prick. So these are some of the assumptions that we would be considering and keep in mind. So as has been mentioned, there are many frameworks that we can analyze a public health case, but we have picked up Nancy Cass's framework, which is a simple one and very relevant to our case here. Usually, as Michael mentioned in the beginning, there are many factors considered before implementing a public health program, like political will, finances, prevalence, or incidence of the disease. But here we will just look at from the ethical perspective. We'll just raise some ethical questions which could arise with the implementation of this project if you go ahead. And let me move the, okay. So as mentioned, there are usually 6 steps or 6 questions asked by this framework, and I have to make it clear that it's not a code of professional ethics, but just an analytical tool which is designed to help us public health professionals to consider ethical implications of a proposed intervention. So the first question usually, or the first step, is what are the public health goals of this proposed program? And we have to keep in mind that we should really set the goal which we really want to achieve with it, and it has to be our ultimate goal. Like we can say that by implementing point-of-care testing, we want to increase the screening, and there could be some incidental or intermediary outcomes like easy access or early detection or early treatment, but what should be our ultimate goal? And so the ultimate goal here is the reduction in morbidity and mortality caused by the HIV/AIDS. So this is our, this could be our goal for this project. Moving along, the second question, the second step is to ask ourselves how effective this program is, would be in achieving the stated goals. So as I mentioned, there are certain assumptions that we have already identified, and the success of the project will depend on sound data that lead us to believe whether the program will achieve its stated goals or not. So do we have data for it, or sound qualitative and quantitative data to justify implementation of this project? We know that two of the provinces, I think New Brunswick and Alberta, either they are in the process of or they have already implemented this project. So do we have data from them? How did they, how the project work in those provinces? Did they evaluate the program? What did they find? Is the program successful there? What are the contributing factors of success? Or in other case, what is needed more in those provinces? So we need to have data to get to the to find out how if the program or the project will achieve its stated goals. So the third question or step is, what are the known potential burdens of the program? So this is probably the question which will look into the most of the ethical questions or the ethical issues that we can face during this project. So usually these burdens or harms fall into three broader categories. Number one is privacy and confidentiality, liberty and self-determination, and risk to justice. So to me, the privacy and confidentiality could be the main concern in this project because of the smaller population and stigma attached to HIV. This could be a main concern of the individuals, and there'll be reluctance on part of the people going for testing. Liberty and self-determination, I don't think this could be an issue because it's people will be going if they want voluntarily, and informed consent will be signed. And as you know, signing informed consent is a practical application of the autonomy. So I don't think the liberty and self-determination could be an issue. Risk to justice and fairness concern are I think there could be a lot of issues related to this. Social harm may arise if the question is raised about the race or ethnicity. Why only we are implementing this project in a northern area? Why only First Nations? Like the stigma attached to HIV that only homosexuals or IV drugs users could be infected with HIV/AIDS. So these are the social harms, or the questions would be asked about this. Why emphasis on northern Saskatchewan? Does it mean that only First Nation are infected with HIV? Harm to distributive justice or resource allocation could be another ethical issue which could arise. We know from our the analysis done from 2012 to 2014 in Saskatchewan, we found out that the point-of-care test, HIV testing, only represented less than 3% of the overall testing. So is it justified to spend resources on this project where we expect such a low number? So the resource allocation question could be another one. Well, let's move to question number 4, and we can discuss some other. So the burdens can be minimized, or there are alternative approaches. So if we go back to the burdens that briefly we have identified, the social, privacy and confidentiality issues, social harm, distributive justice or resource allocation, can those be minimized, or could there be alternative approaches? So those should be looked at before moving